with the MEAM approach. Thanks, Richard. I was on mute speaking. Yeah, that's great. Yep. Thanks, Richard.
Brilliant. All right, thanks. Yes, it's great to be here with you today to chat to you a little bit about what the MEAM approach is. I'm joined by Rachel from Basingstoke. She's going to be offering a few thoughts about what the MEAM approach has been like in Basingstoke. That'll be really good to share with you as well. So if we move on to the next slide. MEAM stands for the Making Every Adult Matter Coalition. We are a coalition of the national charities Mind, which focuses on mental health, Thinks, which is the umbrella charity body for organisations that work with the prison sector and probation sector, Homelessness, which is an umbrella organisation for homelessness charities, and we have an associate member called Collective Voice, which is again an umbrella body for third sector providers of substance use treatment. We came together because we were aware of a group of people that we might call people experiencing multiple disadvantage or people with multiple complex needs. They move between the different sectors that our charities all represent. And are generally poorly supported by the network of services and the ecosystem of services that exist around particular issues. Our remit is to focus on practice change at a local level, so in places like Basingstoke, and also to think about what that means for policy at a national level as well. So if we move on to the next slide. Our vision is simple. So in every local area, people are experiencing multiple disadvantage, and I'll explain what we mean by multiple disadvantage on the next slide. So they are supported by effective coordinated services, and that they are empowered to tackle their problems, reach their full potential, and contribute to their communities. If we go into the next slide. So you'll hear me talk about multiple disadvantage for the whole of the presentation. So this will be what will be useful is to just have a quick idea of what we mean by this. First of all, I would say please take these figures with a massive pinch of salt, and that they are also pretty much out of date, and they need some work. But they are what we have at the moment. Is also the other thing to say about them. So what we mean by multiple disadvantage is some combination of homelessness or insecure housing, interaction with the criminal justice system, and issues with substance misuse. So this figure in the middle of that Venn diagram is about 58,000. This is an educated guess at best. So this is quoted in the Hard Edges report from Lankelly Chase back in 2015, and based on data which is 10 years old. So just to really be very clear about the quality of this data, we think it's an undercount. We know that this really misrepresents the reality for women, Black people, ethnic minorities, and we are actively looking at refining this methodology. We also know with these issues there's overlap with chronic and acute physical health issues. We see mental health issues as well, domestic violence, sexual violence, sex work, learning difficulties, learning disabilities, and neurodivergence as well. So there's a whole mixture of issues going on with this particular population. We go into the next slide. Lovely, thank you. So just to give you an idea of MEAM approach in the southeast, obviously there's a MEAM approach in Basingstoke, but it is also in Winchester. We had MEAM in West Berks until recently, but they've left the network. But there's still work going on about multiple disadvantages. Ada and Worthing as well in West Sussex as well is a MEAM approach area. So if you are from any of these areas and you aren't really involved with your MEAM work at the moment, do get in touch, and I'll make sure that you get in contact with the right people if you want to do more with MEAM locally. Also, there's Fulfilling Lives, which is a lottery-funded programme which operates in the same sort of ways as MEAM, looking at multiple disadvantage. They're in Brighton, Worthing and Hastings as well. So if you can just put the slide on one more, because there's going to be an animation that comes up. Lovely, thank you. I never quite fixed this slide. So this slide as well has got an awful lot of information on it, so I'm going to skim over it as best I can. I always take too long talking about this slide, and I end up running out of time. So this is what we call the MEAM wheel, and there are 7 segments to it, and it gives a framework within which to operate the MEAM approach locally. So the one thing to take away from today is that the MEAM approach is non-prescriptive. So how the MEAM approach works in any given local area will be quite different, but they have common aspects to them which we capture in this wheel. And they're in these 7 segments. So the first one is around partnership and co-production. So that's really around identifying that you've got the right people that are associated with domains of multiple disadvantage around the table, be that operational staff and strategic or more senior staff. And that there's this culture of co-production. So MEAM's use of the word co-production is very much rooted in people with lived experience, and that people who have lived experience of these issues are involved with the decisions made around operational work and are invited into and actively encouraged to contribute to strategic spaces as well. The MEAM approach at a very basic level involves selecting a caseload of individuals are generated from these conversations around individuals, and so this caseload is made up of individuals experiencing multiple disadvantages. So it's very important that there's consistency in selecting the caseload, and that there's a clear referral process for intervention into the MEAM approach, so that all partners are aware of how to do this. The work operationally revolves around the next 2 segments, which are around improving coordination for clients and services, and that is quite a practical activity to make things happen, and to do it in a flexible way as well, so that the types of boundaries that we might offer within our own services or place around our own services rather, they are more flexible when we're talking about this cohort to try and generate better outcomes for the individuals within the caseload. And so this is often around developing person-centred, trauma-informed and strength-based approaches to our work as well. But what we don't want to do is to leave this work just at the operational level. So it's very important that this isn't just a group of individuals we do case conferencing for and we get some good outcomes for a group of individuals. It's important to us the learning taken from this and applied elsewhere within the system, and that there's more change within the system than just for this individual caseload. So the last 3 segments are really around looking at that. So this is around service improvements. So really taking what we've learned from our experiments around flexibilities with a caseload and thinking about what does this mean to improve our service in the long run. And obviously that's associated with workforce development around anything that we've learned. We have the next segment is measurements of success. So that's around our data program that we've got at the MEAM Approach to understand whether this approach actually works or not, to really measure the tangible changes for individuals once they start support and once they end support as well. And we hope that all of this starts to lead into wider systems change and sustainable change, so that those that are in more strategic positions, more senior positions, are able to embed the flexibilities that have been developed as part of the operational work. So that's that wheel in a nutshell. There's a lot more detail to go in with this, but I've kept it as hopefully as straightforward as possible. So if we move on to the next slide. So this is what we might expect to see in a local area. It's typical, but also there are a lot of areas that will do it slightly differently as well. So as I said, the MEAM approach is not prescriptive, so we don't offer this as a model that you have to follow. But this is what a lot of places are doing in order to progress their work on the MEAM approach wheel. So at the top, we have experts by experience, people with lived experience, and we expect them to be interacting with each of the other elements of the MEAM approach in a local area, so that they're involved at all levels, and especially at the strategic level as well, where often the voice of lived experience gets dropped off or missed out. Look at the bottom level, role, and different organisations that are related to the domains of multiple disadvantage. There's a lot of overlap between RSI funded areas and MEAM approach areas. And so what we find in some areas is that the navigator roles often fulfil this role of coordinator, and the coordinator often brings systems issues to the operational group. So we move to the middle of the model, and the arrows that we've got between the different circles are to demonstrate information flows as well. So the coordinator or people involved with intervention for people experiencing multiple disadvantage will talk, they will identify service or systems issues that are blocking them from making progress with individuals. They bring this up to the operational group, and then the operational group hopefully can work together to push that back down the systems flags by being able to make some change for someone in that coordinator role. But sometimes that's not possible. The issue is too big, it's complicated, or they simply don't have the seniority to be able to make that change. And the idea then is that they can move this issue up to the strategic group as an embedded systems issue, and that the strategic group is senior enough to be able to make the change that the operational group needs, and to push that back down as systems change. So that we move from always trying to garner flex within the system on an individual case-by-case basis to grouping things by themes and saying, you know, this thing keeps on coming up again and again and again. We really need to think about maybe there's a referral process we need to change, or an acceptance criteria we need to change for a service, or we need to think about recommissioning a service in a completely different way. And so this model sort of demonstrates information flows between the different levels of seniority in order to hopefully make systems change on a particular issue. So we move on to the next slide. So just to clarify something, sometimes it's easier to talk about what the MEAM approach isn't rather than what it is. So just to be clear, that the MEAM approach isn't an accreditation system. So it's not something that you say, yeah, I've done this, I've done this, I've done this, therefore we can get a certificate saying we're a MEAM approach. We don't work like that. It's something that is not something that you can pick up off the shelf and say, right, okay, we're going to do the MEAM approach, and it can be applied to your area with minimal effort, is something that it looks very different from area to area because local areas have engaged with it quite differently and they've made it their own. It's also something that isn't pick and mix. So the elements, the 7 segments of the MEAM wheel are not negotiable. You need to do all elements of it. Obviously, you won't be doing it at the same intensity or at the same time. I'll say, well, I do this. I won't. For people experiencing multiple disadvantage. Sometimes there's a perception because we have a referral into a caseload or a cohort that then you've referred from one service into another. The idea of the MEAM cohort is that services can come together to problem solve and try and find flex for an individual. So that it's not a service that people referred to as a multiple and complex needs service. It is a framework within a local area to help local areas think about how to do their intervention a little bit differently. So what could the MEAM approach be? Well, as I say, I say it like this rather than what the MEAM approach is, because it's non-prescriptive and it's up to a local area to make of it what it will. But at its best, I would hope that it is an approach which challenges systems to be introspective, and it requires vulnerability from services. It requires them to be introspective and to be open to critique and to learn with partners and to be open to that. It asks services and systems to listen and actively engage those who are most vulnerable, and it does that by upending hierarchies of power through co-production. So who is the real expert about our system for people experiencing multiple disadvantage? Is it us as professionals, as service providers, or is it clients, people who are experiencing these services? It's very much around giving operational staff permission to act differently and to experiment. It's asking for reflection on outcomes from those indulging in what I call negative systems behaviour. So people who are gatekeeping, people who are resource hoarding, people who are overly focused on referral criteria and not looking at the bigger picture. And it asks for systems-wide learning and changes in practice, not just organisational. So if we move on to the next slide. So what's required at the strategic level to achieve this work successfully within a MEAM approach area? So it's about this buy-in and commitment to a new way of working from senior enough representatives across a wide range of sectors. There's this permission from commissioners for operational staff to work differently. That's really, really important. They need to be able to experiment. There needs to be this clear feedback loop from operational work to a strategic work and back down again, so that system barriers can be addressed. There needs to be a commitment to sharing power with people with lived experience. And in many cases, a resourceful coordination post is often required. I think that my slide's finished. So I'm going to pass over to Rachel now. If you do have any questions about what I've asked, pop them in. I've talked about, sorry. Pop them in the chat bar, and we might have time to look at them today, or I'll get back to you on email.
Thanks, Richard. Yeah, I shouldn't be talking for too long, I don't think. Hi, everybody. Thanks for having me on. I wanted to give a little bit of practical examples of how we've administered or been a part of the MEAM approach in Basingstoke and Deane. For those of you who don't know, we are a lower tier authority. I work in the housing team in the district council, and we've got quite a concentrated town centre with some villages and quite it's gone very quickly and we still have loads to do. It's always interesting hearing what should be happening and then following with me and what's going on. But for about 4 years, and I wanted to just give a bit of a feel of how we got there and why we did that. So it was in 2016, it was at a time where our rough sleeping numbers were hitting a bit of a peak. We had about 26 people out, and for our population size, I think that was quite significant for us. Well, for anyone having one person, that's significant. But we were at a point where we were taking on a devolved commissioning arrangement in partnership with Hampshire County Council to look at doing some local commissioning of the outreach teams and the hostels in the area. And we recognised that there was this real will of the community to come behind or come together and look at how we could tackle homelessness and rough sleeping together. So we wanted to, the MEAM approach kind of gave us that framework to move that forward and do something with that. So locally, we, as Richard said, it is very non-prescriptive as a model. So we are a housing-led MEAM approach area with partners collaborating with us together, but the resource very much comes from the housing team and the supported housing sector. Lots of different areas do that very differently, and it's always really interesting to hear how that works in practice elsewhere. But we very much focused on the operational group first. So we're meeting every 2 weeks. So that has dropped down to monthly now, but we were really spending a lot of time building that group of operational partners to come together and problem solve and understand what the needs of the cohort are and were at that point in time. That group's changed. It's changed a lot of membership. We've had lots of people drop in, drop out, but the really core of it is that we still meet really regularly, monthly. But the relationships that have been built up mean those meetings are more now about the themes that come through. There's still that kind of feel of the case conferencey style discussion, but it very much is understanding. We want to move a bit more towards this, as Richard said, but the understanding where the blocks are, where the systems issues are, and coming together as partners and just to really work together and see what we can do for those 10 to 15 clients with the most experiencing the most multiple disadvantage, but also for the wider system and everyone else who's not necessarily talked about. That in practice, that was a lot of cups of coffee, a lot of getting together and talking, getting to understand what the different pressures were in the different areas and the sectors, understanding language and lingo, trying to just the office as it was then, and just meet people at, on a very human level, just to try and understand where people were coming from and what they needed from being a part of the partnership. So that's the operational group. We then, and this is always this, and we'll come on to the slide around where we want to be, but the social inclusion partnership in Basingstoke and Deane always was designed to act as our strategic level element to the MEAM approach, and it does in some aspects it holds that MEAM framework in the area, but it has kind of morphed into it's a big network now of a lot of people who want to be a part of it, want to be a part of the solution, and come together and share learning, share best practice, talk. We find out what's going on locally, and it's not necessarily in terms of seniority. There's the strategic, like how other groups have their strategic group. So that is something that we do want to work on and understand how our that feedback loop that Richard talks about, how that actually works in practice, and that's where the practical help from Richard and the MEAM team comes in. Can we move on to the next slide, please? Thank you. So some outcomes to date. So over the last 4 years, and the MEAM approach is kind of it runs through everything we do, and there's lots of bits and pieces going on. We've been lucky enough to have the RSI funding in the area, and we've got some NSAP funding now as well. So sorry, and so the outcomes we've got, I won't go through all of them, but the big one that I put at the top is our commitment to understand and embed the co-production throughout what we do. We're still on a journey on that. We haven't got that fully sussed. I don't think anybody probably does, and we very much go, are trying to understand how we can just not pay lip service to it and make sure it's meaningful. So we have people with lived experience represented at every single element of our MEAM, the operational group, of the social inclusion partnership, and in all of the reflection meetings that we have around some of the commission services as well. So it's feeding in different ways. sorry, I don't know if we'll come to questions at the end, shall we? The reflective practice and resilience training we've done across the pathway. I know Nick's on the call and is talking a little bit later on, but having that the PI factor threaded through everything we do, and the understanding of that, and we've got a lot of different great support providers in the area, and the risk always was that by having so many it might have felt a bit disjointed as a service, or sorry, as a sector, as a partnership. But we have really invested in shared training, shared experiences, and having that shared reflective to make sure that that's mainstreamed, having the clinical psychologists on board in the hostels is just been something that's a world we didn't really know, we weren't aware of, and we hadn't really experienced before. So that's been really fantastic. And I'm aware of, in terms of the health, I wanted to mention, we have improved our health links. Actually, COVID has really sped that up, and we've got the regional strategic meeting that we have set up by Hampshire and facilitated by Hampshire, but has health colleagues on, that Rich has been a part of as well. And it's just enabled us to build those links in with health, with our CCG colleagues, and understand where their pressures are, and how we can, it's not necessarily always about money, but how we can join up some of our objectives and come together. That's in practice over the years, so that's quite recently, but over the years we've managed to get some GP drop-ins at our local, through the MEAM approach, at our local day centre, part-time day centre. We've had some mental health input at our voluntary night shelters that we've done, and so it's just about building on every year. We try and build on what's happened before, reflect on what's worked, look at where the resources are and how we can come together. Next slide, please. So this is where Rich is always saying, right, what do we do next? Where do we want to go? So back in, just before everything kicked off, in probably January, we had some workshops with the MEAM partners, everybody locally who was involved, including a really, really great session with our peer mentor team, and looking at what are the blocks, what are the barriers, where do we want to go from here, and what's working, and where do we think actually we need to be paying some attention to. And these are probably the most common ones, and probably quite standard ones that we all experience, and it's just understanding as well what our role is in that. So we quite often talk about the mental health services and how homelessness and mental health teams need to work better together, but it's what our role is in that as well as a housing team, and how we can meet the mental health teams in the middle. And yeah, sorry, I keep getting distracted every time it pops up. I keep looking down, don't I? So it's about having those relationships and understanding where we can adapt some of our processes, and as Richard said, giving the people in the operational meetings their permissions to really do something a bit different, but also recognizing where, as a strategically, we need to escalate some of the blocks that we're experiencing, and the SIP just doesn't feel like that place right now. So we're looking at what that could be like, where that could be. Sorry. So I mentioned earlier, another thing we want to do at the start of this, we had some really great input from just different partners that maybe have dropped off, or roles have changed, and the MEAM approach is just, it's not necessarily all about needing to attend those meetings, but it's about how we can make sure people have got an input in them and how they know it's happening. We've got a lot of different things going on, probably all of you do locally, but you've got your high intensity user groups, we've got our antisocial behaviour panels. There's a lot of different groups happening. It's understanding how MEAM doesn't just become another meeting and another burden on people's time, but actually it threads through all of that, and it's not just about that meeting, it's about the relationships and the system work that happens outside of those meetings. So I think the biggest thing for us is understanding that side and maybe that we should have done, I don't know, but the how we've done it is embedded it into the housing team and into the outreach services. So it's just trying to make sure everybody understands what their roles are in it, and how that there is a way to be involved, and that's not necessarily always turning up to the meeting every month, and if that's a resource that that people can't give. So that's a few of our hopes for the next, well, it was going to be this year, but you know, moving forward, and we're pressing on with some of those things now, and just how we can build those relationships. It's all about that, the relationships for us that we've found over the last few years. And I just wanted to, just the last slide for my bit is just a bit of an example of over the years. So some of these people aren't always at our social inclusion partnership meetings, and they've dipped in and out. There's a few old logos on there as well, I need to update it, but the just showing the width of, you know, the depth of the partnership and who we've got involved. I think Outcome Home, I know Nick's talking a minute, I don't think your logo's on there, Nick, so I'm ever so sorry. You're a very valuable part of our partnership. So it's just really understand there's a place for everyone, and as a local authority, our role isn't about being the expert, and it isn't about having all the answers. It's about the how we can facilitate or make room for or broker some relationships, and just step back sometimes or step forward, be the leader when we need to, but also look to where the other strengths in the community are. So there's kind of a very quick overview. I'm really happy to chat with anyone about it, or you've got my emails on, I think, on at the start of the presentation. And yeah, thanks ever so much for having me. I think, Richard, can I pass back to you? I think you might have one more slide or something, don't you? Thank you, everyone.
Thank you, Rachel. I saw someone called Basingstoke Amazing Stoke in the chat, which yeah, I love it. So I've just got this last slide. Now, in an ideal world, we would be having this conversation in the room, and we'd be having these discussions. And I'm aware Rachel's given a perspective from the housing team in Basingstoke, rather the homelessness and social inclusion team in Basingstoke. But this is an approach that can be used by in a local area by with multiple and third sector organisations. So it's not just a sort of a housing-led approach to try and develop systems change. It is supposed to be approachable from anywhere. And so because this is a PhE core, I thought I wanted to just offer some questions to health partners that are on the call and maybe watching this at a later date on the recording, around this type of thinking and how this might help, especially considering the transformation from STPs to ICSs, integrated care systems, around what this type of work could mean for your interventions for people experiencing multiple disadvantage. We're running out of time, so I'm not going to run through these questions, but have a look at them on the presentation. We can send the presentation around. Think about them. If you want to send answers to me over email, or just if this is provoking another set of questions within you, do send stuff over. I'd be more than happy to have a conversation with you actively, or if we wanted to pick up these questions at another session, that's entirely up to you. But I'll pass back over to Emma now, thank you all very much for listening.
Thanks ever so much, Richard and Rachel. That was fantastic. And yeah, I think it might be useful for us to revisit these questions in another session and unpick them a little bit. And also, I, from a public health perspective, I support Hampshire Isle of Wight STP ICS, and colleagues, I have consultant and deputy director colleagues who support the other ICSs, and it may be that it might be useful for me to share this with them as well and think about how we pose some of these questions at the prevention boards that we sit on, as they're all thinking about kind of inequalities and inequities and stuff at the moment as very much part of their work. So really useful questions, Richard, at a very opportune time, I think. So I think it would be really good for us to think about these at a future meeting as well. So thank you for that. I'm going to rush us on to Nick and Saskia, who are kindly going to take us through some of their findings. But if you do have more questions for Richard and Rachel, please do get in touch with us and we can pass those on. And we will pick up some questions that have been posed in the chat bar and pass those on as well. Thanks ever so much again, and we'll pass over to Nick and also Saskia Thorne, who's joined us as well with Nick to take us through their work. Thank you.
Thanks, Emma, and thanks. We'll come on to actually picking up some of Richard's themes, because some of the stuff that we've done backs this up. So back in April, as Emma said, well, this piece of research came from this meeting, you guys, because you started talking a little bit about some anecdotal evidence around the success of more sustainable and interviewing and other person-centered approaches, make explicit use of this theory. So, but we can add to that, and as Richard was saying, that can promulgate up through layers of commissioning. So if you get very, very top-down heavy commissioning, which dictates to the organisations what they need to achieve, that may get fed through the frontline workers, who are then maybe hamstrung in terms of how much autonomy they can get into. If you have really good organisations who insulate the frontline workers from those, so that very kind of top-down outcomes-based commissioning, then you can avoid some of those paradoxical results. So the more you try and change somebody's behaviour, the less they're likely to change. So it was that. So it came. Sorry, this is a collaboration. The University of Southampton carried out the research, Outcome Home and Southampton City funded the research. So we're trying to kind of model collaboration wherever we possibly can, because it seems to be most effective. That was the other bit of anecdotal evidence that came up, is that where collaborations have been successful, it seems to be resulting in some really good practice. Do you mind going on to that slide, please? So yeah, so different approaches seem to be taking, so there's variability and sustainability, and we were interested in kind of trying to investigate some of people's experiences to work out if some of this anecdotal evidence seemed to be playing through. So particularly choice and quality of accommodation seem to be some of the anecdotes, as well as the way in which services were configured and collaboration. And so we wanted to understand people's experiences of that in terms of autonomy, but we wanted to go very open rather than sort of a deductive sort of top-down approach. We wanted to go much more inductive, so much more free. But we were also interested in whether there was any evidence of people's experiences at those different levels, so the commissioners and professionals within Southampton, and how that how messages or the messaging may have affected the way in which organisations felt they had to behave, and particularly the frontline workers, and then the service users themselves. So we conducted some interviews we were lucky enough to get some time with our local commissioners, which is great, and the frontline workers and some service users. We need more data from service users, so we're going to continue this to see whether that's useful. So I'm rapidly getting through this because I want to hand over to Saskia in a minute, who did the analysis of the data and has done a lot of the collection of the data. So she's a research assistant at the university and really knows the data well. Would you mind moving on, please? Thank you. The qualitative method we thought that was really useful because we're interested in people's experience at the moment. We're not really interested in a kind of a hypothesis-driven thing, although we have some ideas about autonomy and some ideas about transmission of message down through the layers. And Saskia conducted a pretty ruthless and robust thematic analysis of all the data that we got at the different levels. Now, this first cut of the data is amalgamated, so all the three groups are amalgamated together, and the themes are interesting in that there's a lot of the themes which coincided. So there's the same kinds of things were being said by the commissioners, the frontline workers, and the. So I'll hand over to Saskia.
these are some these themes and sub-themes are still like being finalised by myself and my colleagues, but given the current situation that we're in, we wanted to get some of the key messages about what did and didn't work in the last lockdown across, so we can influence what's happening currently. So one of the main themes was changes during and post lockdown. So it was really interesting because during the past lockdown, more clients were able to be housed than what are normally housed, and this and became more flexible. Obviously, the directive from the government, so they some people might have had about housing the complex clients and the greater challenges that can come across with them. Also, the throughout the pandemic, it seemed they were bored during lockdown, didn't have as much to do, couldn't go out as much. However, for some people this decreased because they were less able to get hold of drugs and go and beg, or found it harder to shoplift, meaning they couldn't afford the drugs. So as a result of this, a lot of people then wanted to become scripted. And then this is where things got slightly difficult, because in Southampton they decided to stop scripting people methadone, which meant that people didn't want to be scripted because the alternative was Esprinol, and they didn't want this. Because a lot of the pharmacists that were giving out the methadone didn't have the capacity to give out. They quite so it's a possible solution maybe to the problem that we faced in Southampton. It would be great to get more people scripted and hopefully get a bit more of a handle on their addiction. So the next theme was communication throughout the pandemic, and like how the response taken in Southampton was communicated from top down to the frontline workers, and how they could then communicate with their clients. Overall, this seemed to actually be really quite efficient and quite good, with the majority of the confusion or not knowing what to do coming from the fact that the government guidance was a bit iffy in places. Communication that seemed to work quite well from the perspective of the staff was regular emails, whether these be written emails of what's going on, or a lot of them seem to think that having voice memos or some sort going on, they weren't informed of what was happening until it had been decided, and would have liked to have been kept updated as plans evolved, so they could then talk to their clients more and let them know what was going on. So the next theme's like quite broad, probably working on it a little bit more, but I think, as Nick already touched on, collaborative working was a massive positive that seemed to come out of the lockdown and the pandemic. Lots of services and teams within services seemed to really pull together, resulting in some really positive outcomes. I mean, I'll talk about outreach in the next theme because it kind of relates with that. But yeah, that was some really positive stuff, and I think it also helped staff quite a lot because they felt very connected to one another. And also panel increasing was a really, really positive thing, because it meant that they could get through more clients a lot, and found it easier to house people because there wasn't as much backlog as when it was just once a month, and they had it, I think they had it daily during lockdown, and it's decreased now to 2 or 3 times a week, which they're finding really positive. So there wasn't overall too many negative impacts, but the one thing was that there was a reduction in services, so service users had less access to support that they sometimes needed. So I'll move on to the next theme. I'll try and get through the next ones quickly. So the services functioning. One thing that became really positive was the outreach during the pandemic. Again, collective working happened. They managed to get doctors and nurses going on outreach. It made medication and just access to health services a lot more available to the clients. And the outreach was, I think they did it twice daily, and it was really intensive, so they could accommodate as many people as they could. And HFAST, who are the homeless and vulnerable adult support team in Southampton, who do a lot of this outreach, were really, really crucial for engaging those complex clients. And if it wasn't for them, I don't think a lot of them would have been housed. In the experience of a lot of some of the staff that we spoke to, the drug services and mental health services were sometimes a little bit hard to get hold of because of the pandemic, and they thought that this was something that needed to, hopefully, it would be good if they could get hold of them a little bit easier. And then the next theme about staff's feelings is that one thing that I felt really important to kind of express is how some of the frontline staff, in their opinion, felt that the fact that they were on the front line and some of the maybe senior staff and commissioners were working from home wasn't particularly fair and might cause a bit of a rift between them. Obviously, it was a pandemic, and if you can have people working from home, that's good. But there was a couple of senior staff that managed to make trips into the workplace every now and again just to see how things were going, and the staff really appreciated that. The staff felt, generally from the clients that they've spoken to, the B&Bs were very well received from them. The only thing was that they felt clients were particularly maybe a bit happier once they moved into hostels, which were more permanent accommodation. So the approach in Southampton considered factors that had like a direct effect on the client relatively well. They considered client engagement. They very much looked at it from a PI framework, which was successful. This client engagement was a bit more difficult given the situation and like social distancing and stuff, but it did seem to go quite well still. There was variations in client choice and autonomy in their housing throughout the pandemic. Obviously, they kind of had to have the housing that they were given because it was a very quick approach, but there was the option there to house people in different B&Bs depending on their personality and what sort of help might best suit them. So that was quite good. There's been a lot of positives that have come out of the pandemic and a lot of less.
Oh, you've muted yourself, Saskia.
Thank you. Sorry, I don't know how that happened. Yes, there were a lot of positives, and like the main things here are probably the fact that a lot of changes happened to the housing process that kind of needed to happen. So clients who weren't housed originally were able to be housed. Sometimes the housing process was sped up for some clients, so they went into like accommodation that they'd be put in further along in the housing process. And this actually worked really, really well. It was like more of a housing first model. Clients found that they could deal with their addictions more, that they were getting more support, and that they were really, really making some positive progress. One of the things that has stood out as well is a reflective practice for staff. This kind of fell back a little bit during the pandemic, but I think it would have been, or during the lockdown, should I say, I think it would have been good if this carried on as it was, or maybe increased a little bit, just because staff had greater workloads where obviously they had skeleton teams and other staff members had to shield and so on. And then if we go on to difficulties and criticisms and barriers, there wasn't masses of criticisms, to be honest. The main ones, as I've already said, kind of seem to be that some services weren't as accessible. And yeah, that is kind of one of the main ones there. So, and then in terms of client feedback, we only unfortunately got to speak to one client who had been housed in the B&Bs. The rest had been housed in a hostel since before COVID started, but the one that was put into the B&B generally seemed to think it was a positive experience. One thing that he did comment on that maybe wasn't so great was that he shared a room with another individual and they both went out places, so he felt
come out accommodation that they have, and the ability of the frontline workers to be able to facilitate that accommodation where possible. So that seems to have happened, and there's no evidence that people seem to have been constrained or had urgency placed on making people change their behaviours, which freed them up to engage in the choices that the individuals want to make, which of course makes things so much more sustainable. Lots of collaboration. So doctors are very lucky to have a homeless healthcare team in Southampton. Doctors, navigators, and HVAST, and that, because they're kind of co-located, that seems working where you can get some kind of street medicine going as well as the kind of psychologically informed engagement. So outreach is massively essential, and there's some really interesting anecdotes there about not just outreach in terms of engagement, pharmacy available on the wherever people are, and so there needs to be a really flexible process which equally takes account of risk, but a common sense attitude to risk, and probably, if there are conservative attitudes to risk, which are entirely understandable, need to be maybe questioned and more mindful of, to enable this really good outreach work to be done maybe in Weymouth. Respect practice doesn't have to be formal, but allowing the staff to express some of the difficulties, and a forum to express some of the difficulties they're experiencing, and to help them to watch things like urges to tell, urges to inform, urges to the see, give people and help people to give themselves back in that kind of facilitated. Choices seem to be the two big things. Organisations, we do well within the university for other organisations, and people want to be able to voice. And managers within services need to remember to do that. It's kind of hard when you've got a busy workload, and it's hard to remember to value the people that are doing the outreach work. That's really important. No, didn't take evidence of the top-downness of difficulties in communications, because the communication seems to be the guidelines change, and keeping up with the guidelines seem to be an issue. There's something about trying to convey different guidelines, but in a calm way and understanding, so that people can make use of them. Just in case there's any questions.
As an organisation ourselves, certainly the stuff around staff and the need to value our staff. We've done a lot of kind of resilient stuff over the last, since COVID started. As you know, all of our staff are exhausted. The stuff is relentless. Having that opportunity, even if it's just 15 minutes, to have a bit of time to reflect and step back and away from our kind of frontline day jobs has been really important for many of us, to, even if it's just to vent for 5 minutes, has been really crucial. Really good to hear about the stuff coming out around choice, and that was there in some shape or form. And I like the fact that some of it may not have been a major choice. It may just have, or whatever, but there. And I think, can I just ask, you mentioned you have to get some more data from service users. Do you think it's going to be possible? Because that would be really valuable, I think. And I wonder whether we can maybe look at how we could do this in a different area, one of our two-tier authorities or something like that. I wonder whether the themes would be slightly different, or the challenges would be slightly different. I think they would be particularly, but I wonder if there's scope for us to do a bit more.
Emma?
Lovely. Just quickly, we've got 2 minutes.
We've got a framework. We know how much it costs. Patient from service users more because we were struggling a little bit with that. We also need systemic support, so manager support and people to help people. Yes, absolutely. The aim always was to try and roll this out a little bit and to do it somewhere else. So yeah, we can easily do that.
Fabulous. We're now coming up to 1:30, so if people do have questions for Nick and Saskia going forward, again, please do get in touch with Karen and I, and we will pass those on and get some answers. But thanks ever so much for these themes, and hopefully those things that have come out today will be things that will help you as you move forward in your work. Thanks ever so much, everybody, and we will see you in a couple of weeks.